Hello, my name is Kimberly Ann Kerr. This session will give some insights into the treatment and management of chemotherapy-induced diarrhoea. The learning objectives are to describe and understand the different types of diarrhoea caused by anticancer drugs, and to explain the non-pharmacological and pharmacological management of diarrhoea caused by anticancer drugs. The session will go through treatment-induced diarrhoea caused by chemotherapy, targeted therapy, and immunotherapy. Treatment-induced diarrhoea is defined as the increased frequency and decreased consistency of bowel motions or ostomy output. It can be caused by chemotherapy, which is cytotoxic drugs, targeted therapy, immunotherapy, radiation therapy, and graft versus host disease. This session will focus on chemotherapy, targeted therapy, and immunotherapy. Diarrhoea can lead to malnutrition, weight loss, electrolyte imbalance, kidney dysfunction, hospital admission, and treatment delays or dose reductions. Therefore, it is essential to try to prevent diarrhoea from occurring and to ensure that it is treated promptly. Treatment-induced diarrhoea by chemotherapy can be split into early onset and delayed onset. Early onset chemotherapy-induced diarrhoea is caused by irinotecan and sacituzumab govitecan. It occurs immediately after drug administration and is caused by the anticholinergic properties of these drugs. The diarrhoea is also accompanied by other cholinergic symptoms such as abdominal cramping, rhinitis, lacrimation, and salivation. It responds rapidly to atropine 0.25 milligrams to 1 milligram subcut or IV, and this can be administered prior to treatment to prevent acute diarrhoea. Delayed onset diarrhoea caused by chemotherapy and targeted therapy is primarily a secretory diarrhoea and can occur in up to 50 to 80% of patients receiving anticancer treatment. This usually occurs 24 to 96 hours after the commencement of the anticancer treatment. It is more common with the drugs shown on this screen. Non-pharmacological management of this includes oral rehydration, which includes 8 to 10 glasses of clear liquids per day, and dietary modifications. Pharmacological management includes primarily the use of loperamide. Dosing is 4 milligrams at the onset of diarrhoea, followed by 2 milligrams every 4 hours or after every unformed stool, and continued until diarrhoea-free for 12 hours. It is important to note that for irinotecan and sacituzumab govitecan, the dose is higher, with 4 milligrams at the onset of diarrhoea, followed by 2 milligrams every 2 hours for a maximum of 48 hours. The dosing is not capped at a maximum of 8 capsules per day. Diphenoxylate and atropine can also be used at a dosing of 2 tablets 3 to 4 times per day until diarrhoea-free for 12 hours. If diarrhoea increases to grade 3 to 4, which is defined as 7 or more episodes of diarrhoea in a 24-hour period, or if the diarrhoea is persistently grade 1 to 2, hospitalization is required. Treatment includes intravenous fluids plus or minus electrolytes, and drug therapy includes octreotide. This starts at 100 to 150 micrograms 3 times per day subcutaneously and can increase to 500 micrograms 3 times per day. It is important for these patients that bloods, including a full blood count, an electrolyte, and stool specimen are taken, and a treatment delay or dose reduction of the anticancer therapy may be required. Moving on to immunotherapy-induced diarrhoea. This is caused by checkpoint inhibitors, including CTLA-4 inhibitors such as ipilimumab, PD-1 inhibitors, including nivolumab and pembrolizumab, and PD-L1 inhibitors, such as atezolizumab, avelumab, and durvalumab. This occurs in up to 54% of patients receiving anti-CTLA-4 therapy, especially when it's given in combination with anti-PD-1 therapy, and with less than 19% of patients with anti-PD-1 therapy. In this case, diarrhoea may be indicative of colitis and may be life-threatening. It most commonly occurs within 5 to 10 weeks of treatment commencement, but can occur at any time, including after treatment cessation. For grade 1 diarrhoea, which is an increase in the number of motions compared to baseline, is treated by fluid replacement. If it increases to grade 2, which is 4 to 6 loose bowel motions a day, fluid and electrolyte replacement are indicated, as well as a corticosteroid at 1 to 2 milligrams per kilo per day. If it increases to grade 3 to 4, just like with chemotherapy-induced diarrhoea, hospitalisation is required with fluid and electrolyte replacement. A referral to a gastroenterologist is required, and treatment with an IV corticosteroid such as methylprednisolone at 1 to 2 milligrams per kilo per day is required. This continues for 3 days, followed by a high dose of oral prednisolone at 1 to 2 milligrams per kilo per day. For refractory patients, infliximab IV at 5 milligrams per kilo may be warranted for 1 to 2 doses. When the patient's symptoms resolve to grade 1, can slowly taper the prednisolone over 4 to 6 weeks. It's important that patients receive PJP prophylaxis and also PPI. In summary, there are multiple causes of treatment-induced diarrhoea, and it is important to know the causative drug as the treatment is different. Non-pharmacological and pharmacological management is essential. It is primarily fluid replacement and antimotility agents, and hospitalisation may be required in severe cases. The management of immunotherapy-related diarrhoea is different. Steroids are often required, and infliximab may be required in severe cases due to the suspicion of colitis. It is essential to ensure that the patients have a supply of the required drugs at home. For further information, I encourage you to have a look at the references provided. Thank you.